to join. But let's already start the session. Welcome everybody. My interpretation is there is somebody English speaking in the audience. Maybe it's good to, if that's really true. Otherwise we can also do it in Dutch, but...
No, I can see David, so we're in English.
Okay,
yeah.
In English?
Yeah.
Welcome everybody. The session about brilliant business models. We all know, I think, that business models in healthcare are always quite complex. One of the reasons I think why innovation in healthcare is hard to do, because of course the way money flows is important, how you can steer innovation. Jeroen Kemperman from Zilveren Kruis, who also wrote some books on business models, among these in healthcare, will give the presentation a little bit later on. So let's enjoy that. And of course, in the second half of the workshop, after the presentation, we'll also discuss cases that all of you can bring in. Maybe some house rules. We always like it when people have their camera on. Most of you already have it. Paul, Wijberen, David, and Saskia until now not yet. But I think for the presenter, it's always nice when they can see the people that they are presenting to. It's good to have your microphone off during the presentation. You can always ask questions, of course, on the chat channel. And when there's really something you want to say, you can always unmute and say it. But I think the general rule would be, let's first have the presentation and then have discussion in the second half. And like I said, the presentation is in two halves. First, the story from Jeroen. And in the second part of the workshop, we will handle the cases that you all have thought about, I hope. Okay, with that, I think I can give the word to Jeroen, who can start the workshop.
Okay, hi all. And I'm Jeroen Kemperman. I'm responsible for strategy and business development at Zilveren Kruis, and I'm author in the spare time and doing these sort of things in the spare time. Help people a little bit to find their ways into healthcare and into getting, let's say, all the ideas working. So that's me. What I want to do now is I hope that everyone can see the screen. So there's let's say you can see a screen, and there's a Dutch healthcare and the vision, business models, and your own journeys to improve health on the screen, and it's moving as well, I hope. Let's see. Yeah, there it goes. Does everyone, just to check, so I don't, does everyone see the screen, and is it moving? Very good. Okay, then I'll tell a story. I'll tell a story about, let's say, Dutch healthcare, the vision, business models, and your own journeys to improve health. What we're going to do is the following. We're going to start, let's say, from 1330 till 1500. We're going to do, let's say, a presentation. I'm going to do a break in between, because otherwise I'm the time span of a movie, and then I don't believe I'm let's say my sheets or myself are so attractive that you can do that for 1.5 hours. So we'll do a tea break or a coffee break in between, and then from 1530 till 1630 we'll have time to go further, and I guess we can start somewhat sooner, so perhaps it's 15:15 or something, but let's see. I'm going to tell something about the challenges in healthcare, in the Netherlands, vision on the future of virtual care, so what we see as developments, and examples. I specifically brought a lot of examples of brilliant business models to improve health. And then we're going to discuss, let's say, your own journeys and stories. And to start with the end in mind, one of the key outtakes of this lesson is implementation is difficult. It requires technical, financial, and social innovation. So when it feels like a struggle getting things working and implemented, welcome in the club. Actually, we studied now, let's say, 95 brilliant business models in healthcare and in other sectors as well. Healthcare is even more difficult, but in principle, you see things being difficult when you really want to make this happen. specifically when you look at healthcare, then it's about how do you get things into healthcare treatments. So you can have point solutions beside healthcare treatments, but eventually you should be in there. Where does this require, let's say, changing infrastructure and financial incentives and payment structures? How can you share standards? How can you share data? How can you cooperate in that sense? Now we see a lot of solutions which are, let's say, focused and organized around a healthcare provider and not about a patient. Well, it's actually about the patients and it's not about the healthcare providers in theory. In practice, it's not always. And usually this requires also social innovation to make things work. So that makes things difficult, which means that when you talk about, let's say, how you're going to make things happen, how you're going to make a business model which really changes the world a little bit, then you typically see a story in 3 acts. And this is also what we're going to do after the final break, because then we're going to, let's say, share your own stories. And I hope everyone has thought about it a little bit, prepared a little bit. But the question is, let's say the really brilliant business models and new businesses which change the world always start with some sort of why, and specifically in areas like healthcare, where there's a lot of, let's say, intrinsic motivation. People really want to do better, want to help patients, stuff like that. The why is pretty dominant, so it's really driven by vision and positioning and stuff like that. And you ask yourself a question: where do you come from, and what is your moonshot? What do you want to change? Then you see, I'm afraid that getting it working in practice in the business model is also a question of endurance and struggle. So what helpers, enemies, roadblocks, setbacks do you encounter in doing this? And there are always helpers and friends, but there are always also a lot of setbacks and things which are not going as expected. And then we've got nice words for it, like pivot, and then it sounds like this is a modern way of discovering and learning, but it's in practice, of course, also feels like a failure. So it feels like you've done the wrong thing, gone the wrong area and way, and it's a dead end, stuff like that. While at last, when you have a successful business model, the hard thing though is that you cannot predict whether you will end up, let's say, in the sunshine or not. But then at last you'll have, let's say, a value creation for all, and you'll be changed yourself, and the world will be changed a little bit, etc. That's the attractive thing you're doing it all for. But meanwhile, as you know, in the books and in the movies, Act 1 is pretty short, Act 3 is pretty short, Act 2 is actually most of the movie, with the struggling and fighting and stuff like that. So that's good to keep in mind. Now I'm going to start, let's say, the presentation. I'm going to share something about the challenges we face, the Netherlands, the healthcare system in the Netherlands. What you see in principle is we have a pretty huge challenge. We face an aging population, growing need for care and cure, and that's actually the same in all developed countries. And no matter what the system is, etc., you see, let's say, the same sort of challenges we have. And what is the basic background is that when you see since, let's say, the last 100 years, we see people gaining a weekend every week. But so that's the good news. You gain a weekend in life expectancy. So you can have the weekend off, don't do anything, and then you still don't spoil any time because it's free, given additional lifespan. So that's pretty good news. The bad news, though, is that only one of the 2 days of that weekend are spent in good health. And when you look upon people with lower socioeconomic backgrounds, it's even less than 1 day, which means that the gap between, let's say, the health expectancy, and specifically the healthy health expectancy and life expectancy of people who have, let's say, a higher socioeconomic status, higher education typically, or a lower economic status and lower education, is growing. The gap is currently, let's say, in life expectancy 7 years. In the life expectancy in healthy years, it's even 14 years. What you see at the same time is things happening like the number of chronic diseases which grows. So 65% or 65 people of 65 on average have one disease, which is pretty scary, of course. The needed number of people is growing immensely. And for instance, in the Netherlands, the people with dementia, we're having expectancies and prediction that it can grow up to, let's say, 500,000 people, which would be really severe. We don't have, let's say, healthcare places intramural for that. And what you see is in more than 70% of the cases, lifestyle is the main driver of chronic diseases. So specifically when it's, let's say, the metabolism-related diseases, you see that there are a lot of, let's say, lifestyle-related diseases. But also in things like we're now faced with Corona, you see that the complications have a lot to do with the way in which your metabolism functions, and a little bit, what we would call a confused immune system. So when you've got a lot of overweight, but also things like diabetes, COPD, heart failure, then you typically have an immune system which challenges constant chronic infections, and that makes things difficult. And then you even have more complications in stuff like Corona. So a lot of, let's say, the real challenges in healthcare are not even, let's say, curing people and making sure that they don't die, but even ensuring that they don't get sick. So you have to look somewhere else then sometimes. If you want to combat, let's say, overflowing hospitals and an exponentially rising healthcare cost caused by an aging population and shortage of staff, we have a big challenge. So the combination of an aging population, shortage of staff, delivers us with rising costs, pressure on healthcare providers, lesser patient experience, and stuff like that. So we have something to do. When you see an healthcare cost, you see, let's say, the expectancy is that this will double again, and grow further, and yeah, let's say that's a big challenge. While at the same time in the Netherlands, we've got something to fight for. Not everyone is aware of that. We also have the feeling that the system is not good enough, but in principle, we still have the situation that everyone in the Netherlands is allowed to go to, for instance, the Radboud Hospital, one of the finest hospitals in the Netherlands, and everyone can go there. And only, let's say, less than 4% of the world population lives in a country where this is actually the case. Most people live in countries where this is not the case, and where a hospital like Radboud or Anthony van Leeuwenhoek or something like that will only be available for part of the population, and typically the people who are better off, economically speaking. So we've got something to fight for, but there is also a struggle ahead, because keeping this affordable is a pretty severe challenge. And affordable is in this case not just money, but also staff and hands. When you look upon, let's say, the healthcare system and how people evaluate it from the outside world, you typically see that we have characteristics looking from, let's say, other countries to the Netherlands. A lot of people come in there. I give a lot of lectures about this, how we do this in this system, etc. So we've got a Dr. Jekyll side, which means that we usually end up first in a lot of research towards, let's say, healthcare systems in the world. Actually, we're currently in this Euro Health Consumer Index investigation. We dropped a place. We're now the second. The Swiss have passed us, so they were the second. Now they're the first. So we've got something to fight for, becoming the first again. But we're doing good when you look upon it compared to other countries in the world, and that's not just on let's say outcomes, but also on affordability and the way people can access the system, etc., etc. So on the other hand, it is pretty expensive, and that's not just the cure side, but specifically the care side. So what we see is there's also a Mr. Hyde side on things. So when you look upon the cost, let's say the curative healthcare cost, the hospitals, GPs, stuff like that, medicine, they're typically, let's say, they're expensive but not outrageous. The more, let's say, middle of the road in Europe. But when you look upon the care side of things, there are more challenges there. We are the most expensive country actually in the world when it comes down to that. That partly has to do also with our system. We've got really nice and good things in our system, like we pay people to take care of each other. So we, let's say, reimburse people if they cannot work because they have to take care of each other. Which can be, let's say, grandparents taking care of grandchildren, people taking care of their partner, people taking care of their kids and stuff like that, which is all really nice, but also makes it pretty expensive. And you've got, let's say, the long-term care and long-term mental care sides of things, which are also pretty expensive in the world. To give an impression, on average in the world, we've got 9 people working on every 100,000 people in mental care. In the Netherlands, it's 450 people working in mental care on every 100,000, which is a pretty incredible, if you think about it, how this happened. At the same time, that's more the paradox we face. Like with this Dr. Jekyll and Mr. Hyde stuff, we've got more people working in mental care than everyone else in the world, almost. Not too much competition there. But at the same time, we're jointly with Scandinavia amongst the happiest people in the world as well, which is perhaps due to the large availability of mental care, but I'm not sure. And at the same time, we face issues like waiting lines in mental care, and then or in youth care, for instance, the same thing. And then we look for ways to increase the capacity, put in more people, etc., which in principle is it is good if we don't have waiting lines, but somehow we should also search for other solutions than that. If you already have, let's say, 450 people working in mental care compared to 9 on average in the world. So it's a strange situation in which we've got something to lose, something to fight for, something to be proud on as well, etc., etc. When you look upon our healthcare system, you can see it consisting of 4 components. You have, let's say, on the bottom, you've got your social support, which is social care, support, mobility facilities, house adjustments, stuff like that. You've got long-term care, so that's intensive care for the elderly, mental care above 3 years. Physically disabled, stuff like that. We've got, let's say, our basic insurance, which is the prime package, actually, executed by healthcare insurers in a, let's say, public setting. I'll tell something about that. That includes hospital care, pharmacy, general practitioners, mental care, short-term. And then we've got voluntary supplementary insurance, which is pretty tiny in the Netherlands, especially compared to most parts of the world. But that's more dental care, supplementary cover, stuff like that, alternative care, vitality. Currently, we're fighting to get some more vitality stuff into the basic package, but it's not there yet. Stuff like that. Actually, what you see is we're experimenting with 3 sort of systems in the Netherlands. You've got this voluntary supplementary insurance. That's a purely private commercial market. What you see there that actually, to be honest, it does not perform too good, because what you see is that insurance companies like the one I work for, we take out a lot of coverage there because otherwise only the people who take the insurance who use a lot of it, for instance, physiotherapy and stuff like that, and it's pretty predictable as well. So what you typically do is then you create a maximum amount of treatments you can have, and you do that to and make sure that the premium is still affordable, but actually you end up a situation in which the package is pretty tiny. And the people who have high cost cannot cover themselves when it's in supplementary insurance. In the basic insurance, actually on an international comparison, you do really good. What we see is that the cost there for executing the system are less than 3% of the total cost for, to get an impression. In municipalities, usually the cost for executing, let's say, administrative things like payments to people and additional payments and unemployed payments and stuff like that is usually more like 20%, which is pretty high. But it's for basic insurance, it's pretty low. It's 3%. So somehow it's doing pretty good. Well, everyone still has coverage, etc., etc. When you look upon long-term care and social support, we've moved that to a large extent to municipalities. And that was combined with large saving operations, so spend less money, and the combination of bringing it to municipalities and saving operation made things complicated. A lot of waiting lines. It's actually not that. It's still pretty expensive in the world, as we saw. The care side is still the most expensive in the world. So we face some challenges there. But this is actually the Dutch situation. When you look upon the way the basic insurance functions, there are a few things there which ensure that we can use this system as it is. Okay? Oh, Annemarie Willems, let's admit her in. I've done that. Hi, Annemarie. We've got key elements of the Dutch healthcare system, which is introduced in 2006. It's before that time we got a public health insurance and a private health insurance. In a new system, it was combined with public safeguards. So what you actually see is now we execute a public system by private parties, healthcare insurers, for let's say the insurance part. Main principles was accessibility, affordability, good quality of healthcare for everyone. Find a way to enable solidarity in a competitive health insurance market. But then don't compete, let's say, on the package. So the package is set by government and by parliament. It's a fixed package, what's in and what's not in, let's say, the healthcare insurance. We are obliged to insure everyone, which is also good because then we cannot be selective and cannot force each other to only accept the good risks and stuff like that. So to be honest, I like that. We cannot let's say, differentiate a lot in premium. So you can do a collective discount of 5%, but that's it. And additionally, it's the same prices. We are not allowed to pay out dividends, so we're not profit making in that sense. Every quarter you make is, let's say, put into your reserves. And when you want to lower the premium, which is actually the case for the last years, you do that from your reserves. So you bring your reserves down and you bring the premium down at the same time. So actually we're loss making, most of the insurance companies, since the last 5 years. People with lower income classes get an additional allowance, which enables them to pay for healthcare, which is covering it more or less. So in this way, we have some sort of system in which everyone is able to be insured. And perhaps the key thing in that is that there's a risk equalization system. What you see is that there are large differences between, let's say, the rich and the poor, and between the young and the old. So people with more money, better education have, let's say, far less healthcare cost. And people who are younger have far less healthcare cost than people who are older and lower social income classes. So what you see is that we've got an equalization system which gives more money if you've got a patient who has a lower social economic status, and which gives more money if people have, let's say, diseases and ages which are higher, so that you don't have to compete in getting in, let's say, the young healthy people, but you can offer insurance to everyone, and of course you're also obliged to do that, but then you're not stimulated to do something different. How does this system work? The system works as follows. Let me see whether it still moves. It's Yeah, it's moving. This is, let's say, the example one, when you've got a male, 18, 24, but this one is self-employed, higher income in a city, no chronic illnesses. Then the actual budget you'll get from the premium combined with the government is, let's say, almost half of what you start with. When you look upon, let's say, the same male in age, also 18 to 24, but disabled, lower income, rural area, multiple chronic diseases, then you get far more money. And actually, this is a pretty accurate system. It has been in place since 2006. We've optimized every year. Actually, we've shifted a lot of additional risks to this basic insurance system. But it's optimized, and we can predict pretty good what the healthcare cost will be, which means it's still not totally watertight, but it has improved. It has improved. And then you don't have to compete in getting healthy people in. So what you can do is compete on getting, let's say, the best care and cure and prevention as possible for someone. When you look upon, let's say, the market shares in the Netherlands, then you see Achmea being the largest. So we have 5 million people, 4.8 to be exact, people insured. And when you look upon, let's say, our vision and what we want to accomplish, we say we should not just be paying for healthcare, but we also should help people to arrange healthcare, find the best way into healthcare, and improve their health. So we want to have, let's say, not just the obligation to take care of people's health in the sickness, but also in the ensuring that they don't get sick at all, which is pretty logical because 70% of, let's say, the chronic disease is influenced by lifestyle and not by bad treatments. So that means that you are searching for ways to enlarge your role, do more. So let's say you just, for customers, you don't want to be just a payer of healthcare, but also a guide in healthcare, finding your way into the healthcare system and a motivator of healthy behavior. And when you look upon let's say the roles in healthcare, you want to be a partner in health, and you want to be a stakeholder in healthcare sector, and not just a procurer of health. So this is how that works. When you look upon the sort of breakthroughs we envision are needed to ensure that everyone gets good care, the prime focus is how do you bring health close by? So how can we help people in their daily life to be healthy, feel good, be happy, stuff like that. And how can you stimulate people to share and take care of each other? What can we do on prevention? How can we put customers in the driver's seat of their own healthcare? So how can we help them to help themselves and understand their disease and learn how they can feel as best as they can, given the fact that they sometimes have a disease and stuff like that. We want to organize daily care around the patients, also using modern technology to do that. And we want to differentiate in specialized cure where it's needed. So if it's needed, for instance, when it's planned surgery, where there are large differences in quality, for instance, in prostate cancer treatments, you see that there's typically, let's say, you've got in some places the risk on a complication is 35%, and in other places it's more like 15%. So it can be double as risky to go to one place or another. So you want to stimulate people to go to a better place, and that's not always the regional hospital. And when it's a specialized treatment, so for instance, when it's a complicated cancer type or something like that, you rather have them going to the Radboud than to the, let's say, the city hospital in their own municipality. But when it's more daily care and more stuff like that, then the city hospital is fine. Or when it's emergency care, you cannot always afford to go to, let's say, to spend 50 kilometers, 100 kilometers in the car. So there should something nearby. So it also depends upon the sort of care and cure you need, the speed, the complications which can arise and stuff like that. Huh? When you look upon, let's say, one of the big promises in healthcare is the same promise which has, let's say, penetrated and changed most sectors in the world, actually, but not healthcare yet. When you look upon the, let's say, the basic technical developments in the last years, in the last 50 years, actually, you see that digitalization is done a lot on digital communication. So just being able to phone each other. In principle, you can use it in healthcare as well. There you can call, chat, have online contact and stuff like that. Complicating factor there is that people feel that this is something new, which is pretty strange. Telephone is not that new. Chat is actually pretty new, of course. But you see a lot of conservatism in healthcare. Actually, we needed the corona crisis to first, let's say, have on a quite massive scale online contact with people, and then it's just about communicating as you can be face to face, but then on the phone and on the email and stuff like that. What you can do as well, when you look up, let's say, the technological data, you can exchange data, and you can, let's say, if you want to put it into healthcare, you can have a patient's record, you can share patient's record. Actually, we're not that good in that yet. So most patient's records are organized around healthcare providers and otherwise patients. So it's difficult to share data across different healthcare providers, which is yeah, pretty stupid, and yeah, you can imagine that it happens due to privacy legislation and stuff like that. But it's also pretty risky because it means that someone might not know what sort of medicine you have when he or she prescribes other medicine, stuff like that, which is pretty outrageous, of course. But in principle, digital solutions are able to do this. What you can do is you can measure on a distance. This is one of the more promising areas. You can measure on a distance, and that means that, for instance, someone with heart failure, COPD, you can measure the variables on a distance and monitor from a medical service center, which is available and open 24/7. So you can help people from that. And the big promise, of course, is more the augmented artificial intelligence, which is usual on Netflix and in cars, but actually not that usual in healthcare treatments, where we still use, let's say, protocols, and protocols are not always implemented in algorithms, which give warning signals and help you to select a proper treatment and stuff like that, which is not about, let's say, taking over healthcare treatments. That's typically the 5-10 years ago, people thought that this would take over. So either a physical treatment or some sort of augmented intelligence sort of monitoring. But it's principle, it's more often the combination. So you've got an alarm center, which can be, let's say, your medical service center on a distance, but then when you call them up, they can at least look into your data, your full patient record, and look upon your last scores, so your measurement variables. So the combinations of these sort of technologies enables you to do quite different things in healthcare, and might be a way to bring, let's say, in a raw estimate, 46% of your healthcare towards home, which is one of the bigger promises we see at the moment. What does this concern? Not that much surgery. So about cutting at home is still pretty dangerous. Don't do that. But when you look upon other things like diagnosis, etc., nursing and stuff like that, you can do a lot at home. And actually, it's still pretty strange that we used to have hospital treatments, and then people would be in the hospital for weeks. And now we discovered, of course, that that's not necessary, and even that the hospital is perhaps not the safest place to recover from your disease or your treatment or whatever. So you can bring a lot at home. And when you look upon the sort of treatments, kidney dialysis can typically be done at home. Complicated, but but worthwhile to work on. I'll tell something more about later on. Cardiovascular monitoring can typically be done at home, measuring your variables at home. Orthopedics, but then it's more about the recovery and revalidation sort of things, which can be done at home. You don't have to do that in the hospital. And oncology to a lesser extent. And it is about chemotherapy that can be done at home, but controls something else. And of course, let's say the surgery is not something you can bring at home. When you look upon the actual barriers to realizing these sort of stuff, it's actually not clinical. It's also not technical. From a clinical perspective, it has been proven already for a long time in a lot of treatments that it even better results when you do this, let's say, at home than on a distance. Also because you can do it continuously, so you can do it full time when you monitor at home. But it changes the situation. When you look upon the current situation, your doctor is typically, let's say, the hero of the plane. The medical equipment is pretty difficult to understand for, let's say, people who are not a doctor. Nurses are typically taking care of patients, and patients are typically supposed to sit down and don't get out of their beds. Or the old situation in which when I was a kid, I was in the hospital, and then of course they tied me up in the bed. That's more what you intend to do in the hospital. Don't get out of your bed. You only be in the way. But when you change this situation, you end up somewhere else. When you say the patient is the hero and the pilot of this plane, then you need dashboards, which are understandable. You need an at-home nurse who is more a coach in treatments than doing the treatments herself. You need a tailor nurse who is 24/7 available, not one person, of course, so you need some skill to have different nurses, but who can see your measurement scores and see whether there's a reason to panic or not. And you can have a doctor in the emergency cases who can truly help when it's needed, but not always all the time as the pilot. What you would typically see if you implement it, we're experimenting with more, let's say, virtual hospitals. We do this in combination with Erasmus and Karolinska in Sweden, and with Philips, and with our own medical service center, Eurocross. What we typically envision then is, okay, you've got a traditional treatment, face-to-face, small patient group, healthcare provider, face-to-face treatments. Then the current innovation are more or less, a lot of them are still point solutions. So they can, you've got e-health tools who can measure, and the healthcare provider can see the scores. But they are not combined with your patient record and stuff like that. They cannot be shared easily across healthcare providers. So it's typically still point solutions. What you would like is to have, let's say, e-health tools which can be linked to your personal health records and can be linked to medical service centers who have data analysis and have algorithms which say, oh, but when you've got these sort of scores, beware, take care, watch out, because this can be dangerous. So don't stay at home, but otherwise stay at home. These are the sort of things which you would typically measure if you do this. We're experimenting with this right now. This is new SkyCare. We've called this first European virtual hospital. We've got subsidy for that, and we're doing it with a lot of partners, Erasmus and Lots, Roots, you call it actually in Poland, Karolinska, Sweden, with Stockholm Landsting. That is that's the, let's say, the local insurance region facilities. Philips, UAPCO, that's an alliance we're in with all the European healthcare providers with a cooperative background like ours. Zilveren Kruis, that's us, jointly with Achmea and Eurocross, which is part of us as well. What you typically measure then is weight, blood pressure, glucose, stuff like that. And you can measure personal health values, which is more steps, food, sleep, stress, self-scores on well-being and stuff like that. And you can measure, but that's more, let's say, in the long run, and we don't do that yet, environmental conditions and status of patients in the hospital, outside the hospital, and stuff like that. So you can typically do monitoring at home with these sort of things. And then, of course, you want to have, let's say, a system in which you state, when you have these measurement scores and this combination of measurement scores, take this action. So that can be, let's say, nothing wrong, but it can be, oh, but we'll have a nurse looking after you, and she can come by in a few days, or you can go to your GP, or you should go to the hospital to have an appointment, or we should take you to the hospital right away, or send in an ambulance even to get you there as soon as possible. So there are sort of different scores depending upon the variables you measure, and then you're in, let's say, an algorithm in which a treatment protocol, which you always had, which is just a decision rule, like an algorithm. If this, then that. You make algorithms, you change your protocols, you change them into algorithms, and you automate them. So let's say machines can give you warning signals what to do. And specifically when you're in a, let's say, medical service center, that can guide you to take the proper decision and give the proper advice. In principle, this, as like I stated, being tested technically, clinically, and it helps to improve patients' experience. Patients like it a lot to have more self-control. It increases health. People live longer. For instance, when you do heart monitoring on a distance, you typically see that people feel more in control of their own body, take better care of themselves, and even need less medicine. And they also prescribe less medicine additionally, because it's not measured, let's say, once in a month or once in a quarter or something like that, but constantly. So you can be more precise in the levels you need. And typically that means you go somewhat lower instead of, let's say, making it somewhat more to just to be sure. That also means that you can reduce cost, because then you can work more efficient and specifically avoid people going to the hospital who do not have to be there. And in principle, it enables you to give the same sort of care to the same number of people with lesser employee and lesser staff. So when there's real scarcity, this might help. We've learned at the same time that when there's no scarcity, this is usually not adopted. And when it's just scarcity of money, this is not adopted as well. So we see now that the prime driver for innovation is actually this care team well-being. So when people face, let's say, lack of time, scarcity of resources to help people in hospitals, or like now with Corona, the situation in which you're not able to let people visit the hospital, then that typically is a driver for innovation. You need scarcity to have the real breakthroughs. And why is that? That is because there are big barriers towards acceptance and outsourcing these sort of things to medical service center. It's about implementation. What you see now is the paradox we face in innovation with Corona is we need a lot of, let's say, this remote monitoring sort of care. But we typically see that it's not implemented at the moment because people have to spend their time on, let's say, acute cases and acute care. So they don't have the time to innovate and deliver the sort of innovation you would typically need in this situation. So you see, let's say, digital breakthroughs, but that's primarily chats, calling. So doing the same sort of thing you usually would do face-to-face, but now on the telephone. Another reason is changing processes and stuff like that requires time. Financial incentives are not always aligned. So somehow, and that's also to us insurance companies, we are not always able to reimburse things in the proper way. And we don't always innovate in that perspective. So one of the reasons why people did not call but visited the hospital, and why healthcare providers would ask them to visit the hospital, is that our payment systems would typically differentiate between physical or a call. So you would get less money. Well, actually, there's no reason why someone should go there. Why should we pay less? So what's the mess we make? So there are a lot of barriers and risks in getting those things accepted. Of course, the challenge for us all, including ourselves as insurance companies, is we can, let's say, think out of the box and out of systems, and say we need a totally different system, and and the world should be different than it is. But actually, the more challenging way is how can you make the system work for you, and how can you operate it? And what you can see there is, if you want to have adoption, you would typically say, how can you do this within the current system? You would typically say, facilitate something which is innovative. And they're always front runners. They're always people who want to experiment, people like you guys. Go then for the second phase, in which you stay. And that's actually the challenge we currently face. Come from the first phase into the second phase. For instance, there's a lot of, let's say, experiments, pilots, new innovations, testing and stuff like that. But how can we ensure that this also becomes a standard option? And that means, for instance, that remote monitoring of heart failure patients or COPD patients is no longer just a pilot, but it's a regular option which every patient should be able to choose. That's actually what we've also for in politics were the advocate for. We state our let's say insured should be able to choose the digital treatment, which means that you would be able to chat or email, or would be able to have remote monitoring instead of always visiting the hospital, not as an obligation but as a right. So typically step from phase 1 to step 2 is standardize the option as an option, not as obliged. What you can do then on the long run is also change the system and change the standard and change the protocol, but that can be done years later when you discover that this really, let's say, improves health, feels better for patients, saves costs, and costs less staff. And then you can standardize, but it can take a few years. And actually, when you look upon examples, a bigger example where this has happened already is diabetes care, which has really gone and shifted towards home. Now I want to give you a lot of examples of business models to improve health, but let's get a break. Let's get a break. So let's take some time. And let's continue at 14:30, I would suggest, and then you can all have tea or coffee or whatever. We take 7 minutes, and I'll continue then. And it's all right with you.
I saw some questions also. Are all the questions already addressed?
Oh, we can have questions now if you want to.
I saw them in the chat. So Els Slonus asked, what are the numbers? But we're of course a bit further. So what was exactly the context of that question, Els? Can you unmute? You're still on mute, yes.
No, I'm trying. It was a slide where Netherlands was on top of the, so if you go back, compared to other European countries, and I wasn't sure what the numbers would tell me.
Yeah, I can go back, but it's it's 20 sheets away or something like that.
Mm-hmm.
But what you
did, where Netherlands was really on top of all of the
countries. Oh yeah, I cannot tell you. Then I know. That's something. Yeah, what you've got the Euro Consumer Index research to our healthcare systems. It's done in Sweden. It's done every year. And what they actually do is they compare all European healthcare systems with each other. If you are interested, send me a mail. I can send you more information. And what you and of course they're Swedish, so that's one of the reasons we end up in top, is that they really find it important that everyone has accessibility to healthcare. And what you see is when you measure accessibility to healthcare, so everyone has accessibility to healthcare and is able to go to every hospital. There you get a lot of points for that, and that's the case in the Netherlands. It's also the case in this, let's say, 3-4% in the world population who lives in a country where you've got access to every hospital. That's Scandinavia, it's the Netherlands, it's Germany, Austria, Swiss, it's Israel, Canada, Singapore, and you can also count in Cuba if you want to. But then that's it, and not more than that. And that's why you end up pretty high. And when you see in Scandinavia, then there's a lot of waiting lines compared to the Netherlands. So that's where we usually end up above Scandinavia. And compared to Germany and Austria, we're doing it for not too much money. So that's why we do pretty good there. But then again, we're beaten by the Swiss, by the Swiss. Yeah.
Yeah, though I always understand that the Swiss have a sort of the same kind of system.
Yeah,
With
they also,
insurance companies and the basic package and things like that. So
yeah, they've got a basic insurance package, also an equalization system. They've got also GPs, which is of course quite important in our system. Don't underestimate. So it's pretty comparable. Yeah, it's pretty comparable.
somehow I think the system strikes a good balance between the limiting with waiting lists and things like that, and free access while.
Yeah, and what's interesting is, of course, we've got, but it's more frame. In the Netherlands, we state this thing like healthcare is not a market, but actually in the Netherlands, healthcare truly is not a market. Everywhere where I explain in the world what we're doing as an insurance company to private insurance companies, truly private insurance companies, they ask me things like, but why do you do that? Why are you in? If you're not allowed to pay out dividends, why do you do this? Stuff like that. Usually then I say, hey, but we're there to make people more healthy. What do you want for your life? How happy can you get? That's a good reason to work and a good reason to exist. It's meaningful, better than working for dividends. But then in most countries they don't understand that at all. So that's why you just have a few countries where everyone has access. Is that there you've got public systems like the NHS, which actually from this outside people say, oh, but the NHS is pretty nice. But when you talk from people from the Netherlands and from England about the NHS, they all say, yeah, you don't want to be found dead in the NHS system. But then let's say the chance that you're found dead in the NHS system is pretty high. It's really a mess. It's really a mess. And there, of course, you've got some private insurance, but that's really for the happy few. You can hardly afford that if you're let's say middle income classes. Of course, this is also something which says a lot about your culture and your background. That's interesting because in the Netherlands, like in Scandinavia, but also Germany and Austria, Swiss, we feel that you can only be somewhat like a civilized country if everyone has access to this sort of system, and everyone has access to the same hospitals. It would be, for us, it would be, let's say, immoral if not everyone could access the same hospital. And someone would be safe because he has more money or she has more money. But that's how we feel. In a lot of parts of the world, people don't feel that way. Although, let's say, when you look upon, let's say, the international OECD norms, this is the norm. Good healthcare for everyone. This 100% of the population get 100% of really truly needed care is, let's say, the OECD aim.
There's another question from Peter Knapen. Percentage of curative and non-curative is great. The numbers like this for prevention in percentage of GDP.
Yeah, the prevention is really low, of course, as we know. So when you look upon, let's say, raw, really raw, you can state that, but the numbers are in there. But not prevention. But when you look upon, let's say, WMO budget, so that's more the. Oh, there you are, Peter. You're putting them on. Yeah. Now, when you look upon WMO budget, that's a municipality budget. When you look upon long-term care, that's let's say 1/3 of the cure and care is spent on long-term care sort of things, which is more in the law long-term care. 2/3 is spending basic insurance. Prevention is really moderate, but you can do something on prevention in the Dutch healthcare system, but that's now currently primarily for people who at least have some sort of diagnosis. And of course, the big challenge, that's actually, that offers more possibilities than you can think. So it's, let's say 5-7 million people in the Netherlands have some sort of possibility to get a diagnosis. and that can be overweight can be a diagnosis as well, and a chronic disease can be a diagnosis as well. When you look upon, let's say, more the preventive care, so really preventive vitality sort of stuff, that's you cannot pay that for the basic insurance right now. But the possibilities within the system are far bigger than we currently use, and currently the sort of numbers we spend on that is pretty absurd, really low. Well, actually, for instance, we've got a program. It's when I invented it, so it's more or less a kid of mine. It's called Losing Weight with Conditions. So we make some sort of program, and we pay for it if people succeed in the goal to lose weight, which actually 2/3 of the people make that goal. When it's not made, we look upon the reason why, and the reason why might be that someone did not, was not loyal to the treatment, did not show up at the fitness and stuff like that. Then you have to pay for yourself. It's, let's say, 10%. You've got healthcare providers, in this case, fitness clubs and coaches. And we say when someone kept all the let's say all the conditions, went to the fitness, took the food advice, stuff like that, but still did not make it, then it's your fault as fitness school and coach. But when you do make it, you do not make it, but it's not your fault. You've shown up, but it somehow did not work. But there was not a condition which, influenced this. You've got someone dead in your neighborhood, or your family, or you've got you broke something in between. If you got corona, we currently face that, then you don't have to pay. But this program is people on average lose 9 kilos. And when you look up, and it's a program which costs 650 euros, something like that. When you look upon the healthcare cost you save with this 650 euros, that's pretty impressive. 9 kilos is a lot. And this is after half a year, so people gain part of it back, etc. But these sort of investments are typically good, and you usually cannot do that. You could not do that, I should state, within the healthcare system. Now we've got new possibilities to do that, so now we're trying to get these sort of things into the healthcare system.
Oh, well,
but that's a fight, and it's less than 1%. It's more like 0.1% or something. Really preventive stuff.
And under what kind of category do you think this will be expanded?
It can be the
name of that
combined lifestyle intervention.
Okay.
De gecombineerde leefstijlinterventie. That's one of the promising ones, but actually it can also be part of chronic healthcare treatments. So, for instance, when you've got somebody with diabetes, you can also take the same money, and instead of, let's say, giving medicine or giving treatments, you could, in principle, within the system, it's not that simple, but in principle, within the system, you could also give, instead of, let's say, diet advice and medicine, you could also have someone participating in a cooking workshop and learning how to cook properly. And do stuff like that, which is far more daily life and prevention oriented than something else. And to be honest, I always doubt whether you should pay tomatoes out of the healthcare system. I don't think so. Or housing and stuff like that. But you can do far more than we currently do.
Yeah, and is there any incentive for an insurance company to succeed in those new?
Yeah, because the equalization system, in principle, is giving you money given the standard condition of someone, which means that specifically when you make someone more healthy who has already a condition, that's in our advantage. So it's good. There's someone with diabetes, you've got a earmarked budget for that, which is pretty high, as you saw in these examples, with these graphs going up and down, etc. So that is in principle in our advantage. What is not in the system is to avoid diseases. So, for instance, when we do something on pollution in Amsterdam, where I live, when we do something on pollution in Amsterdam, that might, let's say, that's difficult to finance on 2 reasons. one is well, also when it's economically and for healthcare costs, it's really viable to save healthcare costs because you have less need for healthcare costs, less people get COPD, stuff like that. But we are not able to reimburse things which do not happen.
Yeah.
You need conditions, you need an indication because budgets are allocated to indication, and it's related to the same system I showed with the equalization system. So we should compensate for people who have more diseases, but that also means that you cannot compensate for someone who does not have that disease yet. So it's pretty in the pretty deeply rooted into the system of financing we have. So that's why it's difficult. The other one is that it's not earmarked money. When you do something on pollution, it's not related to a person. We've got budgets related to persons, and we should also that's the law, we are only allowed to use it for things which are related to a person and an indication. So as long as you understand that within the system, that you need something like an indication, and then you need to earmark it to a person, then within the budget you have, there is a lot of potential to do different things than we do currently.
Very clear, very clear. Thank you for your answer.
Yeah, welcome. And sorry that I took a lot of spare time. We can still have a tea break, of course.
Yeah, so we take a tea break now for say 5 minutes.
Sounds good.
14:40 back.
Okay.
Okay, 14:40. And a couple of times people asked if the slides will be available, but they will be available.
Yeah, of course they will. Yeah.
Jeroen, while we're waiting for everybody to be online again, would it be possible after the session to exchange email address for some further detailed questions?
Yeah.
Fantastic.
Yeah, we can.
Thanks.
Welcome.
Well, maybe we should continue.
Yeah, let's do that. Okay, shall I continue? Okay, good. Then I'll continue. I give you some examples of business models to improve health. And we do some speed dating there. Of course, the books are still available. So I think I've written, perhaps someone has already gotten it, but it takes a lot of time in the post. But I've put in the post a few envelopes with books for you guys. There's still some addresses I received later, so they're not yet in the post. But in principle, you all receive, let's say, the book Brilliant Healthcare of Brilliant Business Models in Healthcare, the Dutch or English version. And for the Dutch-speaking person, I've included the book The Amsterdam Dream, which is about companies in Amsterdam from the 17th century until now. So I've made some examples from that as well. And so I hope that that gives more information than just the speed dating. But I'll exchange some ideas. Let me see. This is still, again, when I don't use it, it somehow gets fixed or something. Ah, there we go. What you see when you look upon, let's say, brilliant healthcare models and innovation, you see that the actual changes always and only occur when it's truly needed. When it's not needed hard enough, then let's say the established systems as are, or let's say the economical and organizational immune systems to respond to everyone which is new and a threat, etc., is pretty severe. So that means only in times when it's really needed, you see the true innovation happening, and in places where it's really needed. An interesting example is Amsterdam in the mid of the 19th century. What you see then is due to cholera, I don't know exactly how you pronounce that. But you had an epidemic as well in that time, and lack of clean water, and then that gave rise to the upcoming of the Amsterdam Dune Water Company by Van Lennep, who actually had to go to England to find investors for this one. You see, as let's say the prime and most inspiring breakthrough entrepreneur I know from the history of Amsterdam. It's not 17th century, it's 19th century. It's Samuel Sarfati. And what he has done, he has originated, let's say, in the cleaning facilities. So he has originated the city cleaning company in that time, which was self-financing. He sold, let's say, he sold the dust and all the other things as fertilizer outside the city. But he also originated the bakery, which made bread, which is 30% cheaper. He drew industry to Amsterdam because he thought people would need jobs and better jobs, and that would require industrialization. So he get examples from outside. He originated banks, he originated social housing, and it was all due to the fact that he was a doctor and he wanted to improve healthcare. And he wanted to improve the people, the health of the people in Amsterdam. And when you look upon that from an integrative and holistic perspective, pretty modern actually, 21st century like, then you need to invest in things like housing and jobs and cleaning and stuff like that. So you cannot stick to just, let's say, healthcare if you want to improve health. And that's a lesson we can learn from Sarfati, pretty advanced and really in line with the way we currently feel about positive health and a broad perspective upon health. He was actually one of the originators of the General Healthcare Fund of Amsterdam, and that's currently Zilveren Kruis. He was one of the 125 people who were present when in 1846 this let's say processor of Zilveren Kruis was originated, but also the processor of, let's say, the basic insurance and healthcare funds we saw in the 20th century, which to a large extent resulted in the current system as we know it. What they did then, actually, they made a contribution system in which everyone has to pay a monthly contribution, and then you had access to healthcare for everyone, no matter how sick or how much health care you would need based upon that contribution. So that's already, let's say, the model of, let's say, affordable and accessible healthcare for all. Of course, question in our age is we face an aging population, scarcity of personnel, we have a corona crisis. So will that help us and support us to realize breakthroughs in this time? What we did is we investigated different breakthroughs. We investigated, I did that with a number of people, three chief editors for the first Brilliant Business Model books. and I did the last book on myself on Amsterdam. But now we've made, let's say, 95 examples of different companies, and we saw that all these companies in originating past, let's say, 3 acts or 3 stages. They started off from a vision, as some sort of dream about changing the world. And that's why I call this last book the Amsterdam Dream. And that's about the dream people have when they come to Amsterdam and want to realize starting from in this city. But you see in every country and in every company we investigated, which really made breakthroughs, it all started with a dream or a vision, as you could call it. Then it was followed by a more how question, which is more the best business model question. How do you make this happen? And that usually requires a struggle, usually takes a long time. And in the end, you hope that you will get and end up with having, let's say, value creation for all. In which that's not just, let's say, patients, customers, but also employees and the investors and society as a whole. That's how you usually would have brilliant business models develop. What's the frustrating part is, of course, that if you don't have a vision and don't proceed and go through all the endurance and struggle, you will never get at a really breakthrough company. But if you go to 1 and 2, 3 is not guaranteed. So the causal relationship works that 3 is only realized through 1 and 2. But the other way around, doing 1 and 2 does not automatically result in success. And that's of course difficult, because that can take a few years to learn whether it will become a 3 and a success and a brilliant business model or a brilliant failure, as we state. When you make this more simple and more easy to remember, you can also see this as a story. So I'm currently describing it always, also in this last book, I'm also describing it as not as models, but as stories. So you start with a why, you go followed by the how, and then you realize a what. But in the story, it's a love story, for instance. It's you fall in love with your idea, or a boy meets girl, or a boy meets boy, or a girl meets girl, or whatever. Then after 20 pages, you end up in a mess, because then you get separated, there are doubts, lots of questions, you don't share religion, you have father and mothers-in-laws who complicate matters, exes who come in and stuff like that. So everything goes wrong, and then 20 pages before the end, it suddenly goes right and turns out right, and people are reunited and true love forever, etc. That's the sort of thing you would like to have happen when you create a brilliant business model or a dream company. When you look upon, let's say, a different variety of stories is the quests, and there you've got your Lord of the Ring or your Hobbit. It typically starts with being at home, and then you leave home. Why? You could question yourself, but then, hey, who does not want to change the world and have adventures? But then, of course, the adventures truly start, and that's not all that funny, because it's also about setbacks and enemies and complications and arguments and stuff like that. People you can trust, people you cannot trust, etc., etc. Eventually, if it's good, you'll end up having the object found, being successful, having the treasure, and being, let's say, a better person through the experience. Which does not mean that perhaps afterwards you could say, should I have done this? If I knew upfront, I probably wouldn't. But there's a realization at last. This is more how, let's say, the brilliant business models and dream companies arise. So that's why I also challenge you guys to think about, where are you on this road? What is your story? Why do you start? What are the troubles you face? And what is the end you want to have in mind constantly, to enable, let's say, that there's still sun on the light of the tunnel, and it's or light at the end of the tunnel, and it's not a train, as we would state. And to give some examples of how these sort of stories develop, you can see in diabetes care how that has developed over the years. You can say that we come from a situation in which you've got hospital care. It has developed into a situation in people can at least take care of themselves. But now, like we also discussed with this prevention notion, you are in a situation in which you can also turn diabetes around. And we know how to do that. Via movement and losing weight and stuff like that. And people can do it themselves. When you look up kidney care and home dialysis, what you typically would see is that when you look upon the 80s and 90s, this was only done in hospitals. And now it's still primarily done in hospitals with doctors and nurses giving you the treatment. In Rijhof in Sweden is an interesting example. I've included it in Brilliant Business Models in Healthcare of Rijhof, where people have learned to do at least the treatment themselves, still in the hospital, but themselves, which means that they can go there every day a week and also on different times. So they're not forced anymore to just do this in office hours and 5 days a week, which is not that good if you also want to bring your kids to school, or if you want to have a job, or something like that, because it's 3 times a week. So in office hours, that's pretty, a pretty large burden. And you see in practice that it's also more healthy, because on Monday we see that more people die who are on kidney dialysis, and that's due to the fact that in the weekend the hospital is closed, so they can not dialyse in the weekend. So it somehow might be able to do this yourself helps and improves your health. What we're experimenting with is investing in a new kidney to enable more people to do this at home by making, let's say, simple coffee machine-like machinery, which enables you to do these sort of treatments at home. What you see is you've got service centers like Eurocross. We're currently experimenting, like I stated, with bringing this at home as virtual care. A lot of struggle there actually to get this also, let's say, in the system, reimbursed, etc., etc. When you look upon chronic heart failure, we've done this already with HeartWatch program, Hartwacht, as we would call it. We jointly set this one up with Cardiologie Centra Nederland and Briskr. That was one of the first e-health treatments which was reimbursed. It took us a few years to get it reimbursed. When you talk about struggle, this was truly a struggle. While you would state that Cardiologie Centra Nederland is a pretty leading an entrepreneurial organization. Briskr is really innovative and popular and known by all ministries and stuff like that. Zilveren Kruis, we are the biggest health insurance company, so and we still faced a lot of issues to get this into the reimbursement system. So this is how difficult we've made this system jointly, and how difficult it is to get innovations working. Good to keep in mind that in the 95 companies we investigated, we hardly had solution, let's say, examples where it was not difficult to innovate. So innovation is always difficult, and this is, let's say, proof of that. An interesting example we see currently is that we've got PacMed. PacMed is a startup. A startup we actually helped originate. It was originated a few years ago by students. Who are still, let's say, the CEOs jointly. They set up this company, and it's one of the prime examples we know in artificial intelligence, who really use, let's say, artificial intelligence to dig into, let's say, health data and treatment data and understand what works, what does not work, and how you can improve, let's say, healthcare treatments by learning from, let's say, outcomes. And sharing data across hospitals. But currently, which is quite innovative, facilitating the cooperation between different hospitals in IC care in the Netherlands. Also, let's say, starting to do this on the European level. So what you see now is that the treatment paths of IC care with COVID-19 are changed due to the lessons which were shared and learned based on the PacMed algorithms which were developed and the data sharing of PacMed. So this is more or less the future we're looking upon when you think about the future of healthcare. What you see as well is other sort of solutions and other sort of providers. When you look upon Amazon, Amazon has started a project which they call 1492, which means they're discovering a new continent. This continent is called healthcare. So they're going into healthcare. They use, let's say, the Alexa and the availability of, let's say, delivery services and ordering facilities to and strive to, let's say, deliver healthcare at home. So monitor at home, provide medicine at home. For that reason, they bought, let's say, PillPack, which is the largest online pharmacy in the US and currently part of Amazon. They've originated and bought their own data information gathering sort of companies. So they want to do this supply chain as a whole. But of course, the good news is that they're used. Yeah. Was there a question, or shall I continue otherwise? Otherwise, when it's a question, please let me know. I don't see, so just jump in.
Yeah, there were some questions. Jobba Smith, the diabetes is only a success as delivery at home because home monitoring biomarkers is possible. I can hear somebody in the, who is?
Saskia, can you unmute your microphone, please?
Not sure something goes right there. Okay, let's see. There was a question, well, this is not a question. Yeah, Jan Willem asked, are we now, according to you, in a dark enough hour to truly get innovation?
That's a good question, and to be honest, I wonder. I see with Corona that let's say the digital innovation was still limited to primarily chats. And I call and mail my parents for years already, and we use WhatsApp quite often. So it's but in healthcare we started to be pretty innovative. And then I've usually said when you've discovered that Santa Claus or the Christmas man or something does not exist, you cannot go back. So always stated when we've discovered these sort of things, and that also can be done digital, we cannot fall back. And we're also pleading for not having the, let's say, the digital right. So having a right to have digital treatments. But the automatic response is to go back to the former way of treatments with Corona. So it's the fallback in immune systems within the system are pretty severe. To be honest, I'm happy that we now use the quadruple aim instead of the triple aim, because in the quadruple aim, the fourth added, let's say, thing is whether it's good for healthcare professionals and whether it's good for healthcare staff. And to be honest, I don't believe that we will get breakthroughs unless it's good for healthcare staff, which is not just about salary, and people are really, let's say, also motivated to do a good job. But if there's not a problem on scarcity of people, I don't see us changing that fast. So it's still challenging, and it's still not set that we will realize true breakthroughs. The arc is not dark enough. It's not dark enough yet.
Yeah. It's surprising it can be darker even than now, but
yeah. But when you, for instance, when I look for true innovation, I've searched a lot in, for instance, India, and hospitals in India, but also this Africa with, for instance, mobile payments and stuff like that. That's that's the sort of interesting developments. Then that's true scarcity.
Yeah. Okay. And the other question was, what is the business model?
Can we ask a further question about this topic as well?
Yeah.
So when you talk about the benefits for healthcare professionals, do you think it's just it should be easier and less work, less effort, or is it also you know, if they provide better care, it's more motivational for them to be involved in that kind of innovation, because they think it's really beneficial for the patient.
It's all of the above. So you've got, of course, the carrot and the stick, huh? And I would like to challenge, let's say, and I believe that works, healthcare providers on being able to provide better care. So I guess the intrinsic motivation with people is pretty good. And the prime barriers you should solve is not always paying more, rewarding, let's say, what you want to have happen, but also getting rid of all the barriers which are in between, let's say, people giving the best healthcare they can provide. So it's about intrinsic motivation, and it's also about getting rid of the barriers, such as rules that you cannot call, or treatment paths which are fixed and provide a lot of discussion if you do something else or something like that. But then still, I believe that without some sort of trigger in scarcity, it will not happen. So just, let's say, this intrinsic motivation and getting rid of the barriers is not enough, and it should as well be combined with true scarcity. And to be honest, when I believe about what sort of scarcity will really, let's say, do the job, then I think about lack of personnel.
Yeah. Okay.
Thank you.
Yeah.
Yes. Thank you.
But it's difficult to change habits. It's you can compare it with quitting smoking. People have asked me with quitting smoking, what should we do to do that? It's about offering a prevention program, or is it about prohibiting smoking in some areas, prohibiting it in bars, making it socially less, let's say, heroic and less attractive and fashionable to smoke? Is it making it so expensive that you can hardly afford it? Is it cutting advertisement? What is it? And usually I would state all of the above. Is if you really want to change a habit which is so difficult to change, done it myself, one of the most difficult things I did in my life, then you need all of the above.
Okay.
There was another question. What is the business model for PACMed?
Oh, the business model for PACMed is that they sell to hospitals. So they sell to hospitals, and what they offer to hospitals is, let's say, the capacity to give better treatments, because they can improve their treatments working via PACMed. When I think about, let's say, what really does the trick for them and is the magic bullet for PACMed, I believe it's not just, let's say, again, this intrinsic motivation to give the best care, but I also believe this is about toys for boys and for girls in healthcare, but it's increasingly girls. But I guess that people all also want to, let's say, exploit new knowledge, learn from this, etc., etc. So I guess in the long run, one of the key things which PACMed could do in, let's say, having hospitals as customers is to ensure that these hospitals gain status, become better in their reputation, have a possibility to publish, have a possibility to learn treatments, but also toys for boys. If everyone else has it, they want to have it as well.
Like robot surgery.
So they pay, hospitals pay a monthly fee to be part of this.
To that, yeah.
Yeah. Okay.
So it's subscription model. Yeah, sorry, it should be. I've given a far complicated answer than this. Subscription.
I've talked a lot with them in the past. I know they do have a difficult time in switching from earning money project-based, because they did a lot of subsidized projects around this, and getting to license fee-based, and that's for a company a difficult move to make.
Yeah, it's really a difficult move. I mean, the advisory board and investment board, etc. And then quite good. Yeah. But you're fully right, Martijn. This is a really difficult transformation. Actually, this transformation a lot of software companies make, going from, let's say, project-based financing to the fixed subscription basis where you can grow.
That's and that's also one of the questions or challenges we would like to bring in later on. But to have a further question on this, the PECMED projects are done in the hospitals, but how are they financed? Is this from out-of-pocket money, innovation budgets? Because
essentially, the subscription should come out of regular treatment. So in the hospital is paid for, but it's like when you've got a treatment, for instance, for a hospital gets money to take care of someone with chronic heart failure, for instance. So that means that when you think about remote monitoring of someone with chronic heart failure, you should do that for the same budget, but then instead of having people visiting the hospital, it should be used to do remote monitoring. So the challenge always is find the diagnosis. That's why I spent some time on that. Find the diagnosis, find the budget related to it, and see, and that's where I advocate not just thinking out of the box, but also making the box larger and working from within the box. Find ways to use this money on a different way. And when it's just added cost, so you still get them into the hospital, you do the same controls, but additionally you've got something else, then it will not work. And actually that's important to keep in mind, because for a lot of people think that they should go to an insurance company and get some additional separate reimbursement for this or something. But usually in innovation, I would say that we should back off. We should enable hospitals to use everything they can to give the treatment. We don't pay separately for a bed. We don't pay separately if you do 2 photos instead of 1 photo. So it's you give a budget to take care as good as possible and remove the barriers to do everything you can, and to use innovation to do that. One of the examples I would truly like, for instance, in dementia care, is Zorgerf, healthcare farm, whatever, people with dementia. It activates people, and there are a lot of, let's say, animals walking around there. So there's always an animal to feed, or to walk around, or to look at, etc. And it activates and is part of the enjoyment of being there and stuff like that. Helps a lot. But we don't reimburse rabbits. We don't reimburse cows or something like that. They use them within their total system and treatment and residents. And the same is for most apps which are used in a treatment. It's part of it. Should be.
Okay. Do we have still some time for there's one other question. How did HeartWatch get reimbursed?
The same. So it's the same. It's remote monitoring is now part of the treatment. In making it happen the first time, we put in some additional money, but also made appointments about reducing reimbursement in the future. And then we still had a lot of discussions with ZIN, Zorg Healthcare Institute in the Netherlands. And actually that cost us 10 months. It was 10 months waited there on approval, and we phoned and called and mailed and put pressure on it. And eventually it appeared that this 10 months, all of the time, let's say one person had, let's say, stopped this innovation from being paid. And not because they said it was bad, but it was not proven that it was better. But we would state, and that's usually what would happen if you've got these 3 phases. First, facilitate the experiment, then go to second phase, in which this at least is an option. And the third phase is, then you can prove that this is superior and you can cut and skip the other treatments. You just do this. But that's not where you start. You should start by just facilitating the experiment. But it took a lot of time.
Yeah. Okay, and Els made a statement more, but then you're still using money which is spent anyway, fighting disease. Maybe you can explain a bit, Els?
Well, that was relating to if you're looking for the money, if I understand correctly, you have to look money which is allocated to a diagnosis, to a disease. And then you might offer an alternative for spending that money, which is spent on medicines or whatever, the traditional treatment. but then you're still spending money, which is spent. I'm thinking of the prevention. So if I have a business model which is preventing something, but it's not allocated to a disease, where do I find that money to pay for the invention?
Yeah, and the bad news is not. Sorry. Yeah, and the bad news is, and really the bad news is
too early.
Then,
not
you can.
Yet.
Then you can go. Let's say the out of the box thinking is more or less. Oh, but then the total system should be changed because this should be paid for because I save money in the healthcare cost, but we don't have budgets which work that way. We've got earmarked money, so we're not allowed to pay for it as healthcare insurance companies. So what you should do then is search, is there someone who has who is able to pay for this? And that can be when it's when you can find a diagnosis, and that's far often more possible than you think. Huh? When you can find a diagnosis, which can also be overweight or something like that, then there's a possibility within the healthcare system. When there's not a diagnosis which can be related, for instance, it's health pollution in Amsterdam, which is really causing trouble, but we cannot do anything about it. Then you should find other resources, which can be the municipality or the government. Or it can, for instance, be the employer. We do a lot with employers, and we use employers a lot to finance preventive sort of interventions, because employers have also a lot of, let's say, shared interest with us to keep people healthy as possible.
It means vitality and prevention from burnout.
Yeah, in those sort of areas, you can typically think about the employer. And we also have, let's say, municipalities when it concerns people, for instance, who are unemployed and stuff like that. But it requires a lot of, let's say, understanding the system from within and trying to change and let it work for you instead of against you. And then, sometimes the answers are nice. So the system does the proper things. For instance, I like the fact that that we're able to ensure everyone has access to proper healthcare, and we are not competing like in most countries on getting just the healthy people in as insurance company, which is all really good. But I don't like the fact that we cannot do enough on prevention. I see within the system that we've got possibilities to do more on prevention, also on a regional level, but it's still not possible. So we're fighting for it, but it's still not possible. When I would have a startup, I would not, let's say, make it depend upon, let's say, the ideal world, which is not yet there, but be creative within the system. That's more or less the challenge. And when it's about burnout, for instance, it can be the employer, it can be the municipality, it can be the healthcare insurer, but then you need some sort of diagnosis. So when it's about 100% of the population helping them, for instance, like we discovering now, to feel better, understand themselves better, but then for everyone, then it's difficult. When it's about someone who already has some sort of complaints, then we've got something which can be diagnosed. We've got 4 million people in the Netherlands with a mental disease. So there's a lot of diagnosis there.
I'll go back to it later. Thank you.
Yeah.
Yeah, I have a lot of, some time ago I made some graphs that really show, maybe if we have time later on I can show them, that really show that prevention is never a business case. Prevention is never going to help us lower the cost in the healthcare system. Because maybe we can come back to that later.
Yeah, I'm almost finished with this part of the presentation. There was just one more example. That's this, of course, what we see happening in China. And what's interesting in China is, of course, that they've said we don't want to have, let's say, the social tech companies taking over, so we do it ourselves. And so they just made it forbidden. That's also a different way of looking upon the world than in Europe. But I don't know, eventually, perhaps they won't do quite. They invented, let's say, WeChat, and WeChat is now paying. It's a WhatsApp combined with payment functions, combined with ordering functions, combined with Facebook, etc., etc. and they're more into, let's say, the health insurance companies where prevention is included, but then that means automatically that that if you don't work on prevention, you cannot be reinsured or insured. So, or you pay far more premium and stuff like that. That's actually what happens when you put prevention in. But when you look upon artificial intelligence, the way that is used, then China, of course, is the leading example, both in the number of patients and in the lack of privacy legislation. They have a lot of possibilities to be faster and sharper than we are, I'm afraid. So this is at least interesting stuff to look upon. What's of course one of the light points for us is that the Chinese market is so big that for the time they've got a lot of things to do within China themselves. But if they want to really take over in artificial intelligence sort of applications, they've got a lot of, let's say, they've got a good hand. This is so we're now going to your own journeys and stories. Like I stated, it might be difficult to get financing. We already have a discussion about that. Opening up healthcare treatments, change for infrastructure, finance, how do you do that? Set and share open standards, change human habits, change behavior, stuff like that. And of course, the question for you always, and I hope we can get around. I don't know if we first need to grasp a cup of tea or coffee, or we do a break in between. But it would be nice to share some stories here. And I'm not exactly sure, Ask, how much stories we have. So perhaps we should count a little bit and see how much time we've got left and how we can share. Because we've got more than an hour left, perhaps a few minutes to get tea or something. So,
maybe it's good to inventarize to the who would like to bring in a case. I see 1, 2, 3, 4, 5, 6, 7, 6. I think 6 cases that I see.
okay.
And David also is hand up there. It's 7, I think, even. Until what time do we have?
It's 16:30, I think. So it's more 10 minutes for each case without break.
Maybe best to first take a short break.
Yeah, I think so. And then we go for 9 minutes for each case, something like that. And we'll manage that. We get 16:30. We'll ensure that we get that as well. So.
Very good. We take 5 minutes and the 27, everybody back sharp. Thank you.
Okay.